This hearing on the 2009 budget request for the Department of Health and Human Services. This hearing gives us an opportunity for members to explore the President's budget request for HHS in greater detail. I'd like to thank Secretary Leavitt for appearing before the committee today, and not only that, for accommodating our schedule change so that he could be at the hearing. We appreciate your coming again and look forward to your testimony. The HHS budget should be considered in the broader context of the President's 2009 budget, which continues the same policies as previous years but with more dramatic effects. To help pay for the nearly $2 trillion in tax cuts over the next 10 years, the budget cuts Medicare by $556 billion over 10 years, more than double the cuts included in last year's budget. It also assumes legislative and regulatory cuts to Medicaid totaling $81 billion over the same period of 10 years. These cuts will harm states' ability to serve the uninsured at the same time they're experiencing budget shortfalls due to their own circumstances. The budget for HHS also cuts or freezes vitally important public health programs that are essential to increasing access for the underserved or making advances in medical research that lead to improvements in health. The budget includes cuts to several safety net programs, which are vital to supporting struggling working families, such as LIHEAP, the Low Income Energy Assistance Program, and SSBG, the Social Services Block Grant. These cuts will harm millions at the worst possible time, just when our economy is on the edge of recession, just when employment is declining and Americans are depending most on these programs. We recognize the long-term challenges facing the budget. It is important, however, to keep in mind that this administration has aggravated those challenges through its policies, mainly large tax cuts resulting in the largest tax deficits in history. These deficits have led to a moratorium of debt that prevents a mountain of debt, I wish it was a moratorium, a mountain of debt that prevents resources from being used for other priorities. It's also worth noting that while the administration has focused a great deal of time and energy on privatizing Social Security, the President signed into law the Medicare Modernization Act of 2003, which created an even larger unfunded obligation than that of Social Security. As we consider the problems facing the federal budget, we should keep in mind that Medicare and Medicaid are experiencing the same challenges facing the health care sector, notably the rise in excess cost growth. Cutting Medicare and Medicaid to meet budget targets alone without addressing the underlying structural causes of excess spending growth, we fear will only lead either to shifting costs to other sectors or to putting beneficiaries at risk. Earlier this month, Congress received the administration's Medicare proposal to address the trustees' Medicare funding warning. We're eager to learn more about this proposal and whether or not it would result in cost shifts and actually address the issue of cost growth in the healthcare delivery sector. The challenges ahead of us are tremendous, and we appreciate Secretary Leavitt's presence to help us understand the administration's views and his own views on these particular issues. But before turning to the Secretary for his testimony, I want to recognize the ranking member, Mr. Ryan, for any comments that he may care to make. Mr. Ryan.
Thank you very much, Chairman. Welcome back again to the committee, Secretary Leavitt. When you testified to this committee last year, one of the important points you made was this. You said that we do not have a healthcare system in this country, that we have a healthcare sector. It's a concept you repeated at the Ways and Means Committee, which I serve on just recently as well. And you said that healthcare should be, quote, a private market where consumers choose, where insurance plans compete, and where innovation drives the quality of healthcare up and may drive the cost down. And that principle, as I understand it, underlies much of the administration's approach to healthcare, including the President's health tax proposal. This is important because it goes right to the heart of the healthcare debate. If there are problems with healthcare, they have not come about not because the market has failed, but because of distortions imposed upon it over the decades. Those who think they can fix healthcare with more government spending and intervention, I believe, are headed in the wrong direction, and consumers and patients will suffer for it. Let me just cite two examples, both of which are relevant to the budget we're considering. First is health insurance. Most people in America who have health insurance get it from their employers or the government, that is, from third parties. And this is mainly because of an accident of tax law that goes back to World War II when there were wage and price controls. What's odd is that we don't expect somebody else to choose our cars or refrigerators or our clothes for us, but with something as important as health insurance, we do. It's no wonder some people get frustrated about their coverage or feel in danger of losing it. They're not calling the shots. Second is government spending. About 35% of the $2 trillion we spend on all health care nationally comes from two government programs, Medicare and Medicaid. When government pours that much money into any sector, it's going to affect prices and distort the practice of medicine. In other words, one of the reasons health care costs are rising so rapidly is the huge amount of spending and distortion and control that the government pumps into it. These programs also affect the benefits and pricing of private health insurance because they create benchmarks that commercial insurers fall back onto. The point is this: the key to both controlling health care costs and expanding coverage lies in removing the distortions in the market. That means several things, including ownership. Health insurance should be owned by the people who use it, and we can accomplish this by shifting the current tax benefit from employers to individuals and families, so we're not discriminating against people who get it from their jobs only. We can debate whether there should be a deduction or a credit or what have you, but the point is that it should be changed to promote personal ownership so you can move job to job with your health care. Transparency. One of the big problems in health care is prices are opaque. In Milwaukee, I've done the research. You can pay anywhere from $47,000 to $100,000 for bypass surgery, anywhere from $600 to $5,000 for an MRI at the same procedure at the same hospital. But most patients, and sometimes even doctors, don't even know this. Entitlement reform. Something that is missing from nearly every major healthcare reform plan being discussed is that they don't include fundamental fixes and reforms to Medicare and Medicaid. As I indicated before, unless we reform those programs and moderate their unsustainable spending growth, they will continue adding to medical inflation, and healthcare reform itself will fail. The President's budget does address these issues. If you could pull up chart number 1, please. And it tries to foster a truer, more efficient marketplace. We may not agree with every specific proposal that the President offers, but he does point in an important direction that we ought to consider. I look forward to discussing these issues here with you today, and I also look forward to discussing the Medicare trigger. But before I conclude, let me simply say this. We're going to be marking up the budget resolution here next week. And if the budget resolution that comes to the floor does not include any reforms to the Medicare program to save money, then we will be forced with adding the unfunded liability, which is today stands at Medicare at $34 trillion, which is about $300,000 per household, to $45 trillion over just 5 years. That means if Congress neglects its responsibility and its duty to do something to save and rescue Medicare, we will add a debt that goes from $34 trillion today to $45 trillion for the time when my children need this program. It is irresponsible of us to not take this action. So when I hear the word cut, the word cuts to Medicare as are in this budget, I simply look to the fact that under this President's budget, they are proposing to increase Medicare spending at 5% a year. If it goes up 5% from last year to the next year, that is not a cut. That is an increase of 5%. And with that, I yield.
Mr. Secretary, thank you again for coming. We have your testimony, which was pre-filed, and we'll make it part of the record so that you can summarize it as you see fit. I might mention that when you were last here and testified last year, we talked about program integrity funding, and we put in our budget resolution, which passed, some substantial additional money for that very purpose in order to get at the problem of waste, fraud, and abuse in the programs under your jurisdiction. Unfortunately, that money was left on the cutting room floor when the budget was downsized at the President's insistence and we negotiated the omnibus for this year. I would hope that we can do something next year, and would like your testimony, if you could, as to how bad the problems are and what can be done with additional program integrity money.
Thank you, Mr. Chairman. At our meeting last year, I recounted experiences that I had personally had going out with Office of Inspector General agents, particularly in southern Florida, where I saw firsthand fraud and abuse. I saw office buildings full of what were very clearly shell businesses that had been established solely for the purpose of defrauding the American people and Medicare beneficiaries. Essentially, they work in the same way. They set these up. They get a billing number in the same office building. They're able to use find someone who can rent them names and lists, who can, in fact, then begin to bill enough claims against Medicare that in a course of 4 or 5 months they can collect and then close down and leave. And they do it over and over and over again. I think I may have related the story last year where the week I was there, the Inspector General agents had been able to procure access to 3 or 4 of the front people, not the people behind them, but they were able to get them to empty their bank accounts out. And I held checks for $10 million where they had simply written checks to clear the accounts out. We're talking about hundreds of millions, billions of dollars. You were very gracious last year in this committee in being able to designate about $300 million plus for that purpose. This money pays dividends in multiples. I'm talking about 4, 5, 6, 10 times the amount we spend, we get back. I'm appreciative of a chance to reinforce that. We hope very much that could be considered in this budget. It just needs to happen every year. We don't do it. Money is going out the door. It continues. We have done a number of things in the meantime. We've changed. We're in the process, for example, of requiring that those who put durable medical equipment out in certain areas have to post bonds. We're essentially making everyone requalify. We're doing everything within the resources that we have, and we're having some impact, but we need additional resources so we can do it in other areas. I have posted my statement. I won't review it other than to just say 3 things. The first is this budget is very clearly directed at trying to balance the budget, at trying to sustain and put entitlements into a sustainable place, and to make certain that premiums are affordable to beneficiaries. I have grave concerns for all of the reasons that have been spoken already by Mr. Ryan. Medicare warnings have just become a seasonal thing. They come and they go like the cherry blossoms, and when they happen, we all stop, pause, and say that's a serious problem, and then move on without taking action. I hope this budget will at least be viewed as a warning. Every year, whoever sits in my chair, whoever sits in your chair, ultimately is going to have to deal with this until we do, and they'll be facing the same kinds of issues that I've raised in this budget. I've gone through and done the best I could to find ways in which you could make the budget balance. I would suggest this is not reform. What this is a budget. It's a budget just doing the best I can in what I think is a broken system. This is a government-regulated, price-setting, centrally planned system, and it will always produce choices that won't reflect a solution. And so I'm hopeful that in the course of this, the budget, while it will make a lot of people unhappy, at least it will raise the one more warning that we have to deal with this. Now, I recognize that there is a need to come up with a solution, and hopefully we can talk about solutions. I believe many of the same things Mr. Ryan said earlier, and that is the need for us to make Medicare more about educated consumers. And when we do, I believe there's a means by which we can begin to turn the tide on this and create a true system. I know there'll be lots of questions, and so rather than take more of that time, Mr. Chairman, I'll just yield whatever time I have left back, and let's go to the questions.
Thank you, Mr. Secretary. One of the issues we have dealt with in the past year is Medicare Advantage, which was tucked away in the back titles of the Medicare Modernization Act, which primarily dealt with the addition of a prescription drug benefit to the Medicare program. CBO has told us that the differential on average in payments per beneficiary under Medicare Advantage as opposed to traditional fee-for-service Medicare is 13%. In other words, this program, Medicare Advantage, which was intended to be a managed care option for Medicare, and therefore to save money, instead is costing us more money than traditional fee-for-service Medicare. Number one, do you disagree with that? And number two, have you seen the particular graph that was published by CBO, which shows that given the differential today and the likely growth of this program, because it is better funded, that the cost of providing for care of beneficiaries under this program over 10 years is likely to be $150 billion more than fee-for-service beneficiaries?
I am aware, I was not here in 2003, but I'm aware that the Congress made a decision to expand the program on a countrywide basis, and that they established the pricing in a way that would accomplish that. I'm also aware that they chose to have that additional that additional pricing reflected in benefits, and that it has clearly worked, and that people are happy with it, and that they are in fact enrolling in large numbers, and that we've now accomplished some 20% of the beneficiaries who have chosen it. I'm also aware that those who enroll, not only are they happy because of the additional benefits, but because they're having an easier time getting a physician. Now, do I think it's perfect? No, I don't. But I think it's a very positive move toward the kind of thing I spoke of earlier. I've indicated in other testimony that I believe there are some things we can do to refine it, where the actual bidding that goes on is done in broader areas, and we'll begin to see competition drive the cost of it, not just down to where it is now, but perhaps lower. I think we're on the right track. We just need to continue to work and refine it in ways that will allow the market to work and for consumers to have the choice that they...
Well, do you plan in the near term to equalize the cost between the two programs, or at least to remove this 13%, 14, 15% advantage?
I personally, well, again, I want to acknowledge the fact that this additional amount is going into benefits for beneficiaries. I think we can probably concur with that. I also believe it does need to be allowed to make certain we have a fully implemented national program. I also believe that if, in fact, we were to expand and refine the bidding process, that we'll see a market begin to not only drive it down to where it's equal with existing rates, but below. I think we can see it not only come to the point that it's equalized, but go below, because I believe that's the power of the market that it will unleash.
In your quest for program integrity, and I commend you for that, have you encountered waste, fraud, and abuse in the marketing of Medicare Advantage policies?
Yes, we have.
Would you care to elaborate on that?
Well, it exists, and we're doing everything we can to, just as we are in other areas, to remedy that. And unfortunately, when any program of this nature, and I'm not talking just about Medicare Advantage, I'm talking about Medicare, we have to be vigilant and pursue not just integrity in that area, but in every area.
About 10 years ago, as part of the package deal that became known as the BBA, the Balanced Budget Act of 1997, the package included a sustained growth rate factor. The problem being that when we bore down on rates, we tended to see volume increases in the delivery of health care to make up for the reduction in rates. That's become a problematic ratio these days, or equation these days, so that for 3 years in a row or 2 years in a row, we've had to correct it, patch it 1 year at a time, feeling that it would not be fair to administer the kind of cuts that it called for to physicians' pay in particular. We've been waiting on some kind of resolution or correction of that particular formula, given the fact that it tends to produce anomalous results. The administration has indicated in the past that you were working on it, but we've never seen anything. Nobody has seen anything up here, and so consequently we go from year to year to year correcting the problem. What's your solution to the sustained growth rate factor?
Well, first of all, let me just concur with you. I think it's a lousy system. And I think it's anytime you have a price-setting, centrally planned system, you're going to end up subsidizing the wrong things and overcharging for others. And in Medicare, we make a couple of thousand decisions that begins to drive all the decisions that consumers could make, I think, more wisely and more precisely. At the root of this problem is the differential pricing, where you can go to Mr. Ryan's state in Wisconsin and see a rate that's half what it would be in Milwaukee, or rather in Miami. You can't find any difference in the outcomes, but what you will see is that the minute we begin to reduce the rate, they just start performing more procedures. There's no competitive or consumer pressure to drive those down, and frankly, that's one of the things that I believe we've got to unleash in Medicare Advantage.
And part of the problem is that conscientious doctors who are not responding by volume increases are nevertheless penalized the same as those who are.
Well, that's what happens in a price-setting, centrally planned, government-regulated system, and we need to change it.
Well, what's the change then? Surely you're not talking about privatizing Medicare completely just to get at that particular problem.
No, but frankly, if we could begin to see Part A and B look a lot more like D, we'd begin to see the impact we've seen on D. I mean, on D, we started off believing the actuarial, I mean, there were estimates all over the place, but if you figure where it was finally adopted at $37, we're now delivering it for $25. We announced last week, I think, a $247 billion reduction in the original estimate. Now, there are lots of things that go into that, but everyone I know, including the government actuaries and any economist that you'll find, will tell you that a big part of that was competition. We adopted regional competitive environments where, in order to get business, people had to be the least possible rate and they had to offer the best possible service. And people had a choice. And we've now seen quality go up and the cost go down. And so I fundamentally believe that the way we ultimately begin to get at this cost escalation and the way we begin to convert it to a systemic to a system is that we adopt the same strategy in Part A and B that we have in D. And that D remains a government-regulated but market-driven system.
Well, given the situation now, has HHS with MedPAC tried to develop a better formula than the formula now in place for sustainable growth rate?
Well, we welcome the opportunity to work with Congress. It's obviously going to take legislation to do that. If it was just up to HHS, I'd have come up with something, but at this point it's a matter of legislation, and we look forward to working in whatever way. We've got to fix it. We just keep patching it from year to year. I mean, from 6 months to 6 months. We don't even make a year these days. So I'm not here today to say I've got the formula in my pocket, but it's something worth working on.
Okay, thank you very much, Mr. Ryan.
I'm going to deviate from what I was actually going to ask because I thought that line of questioning was quite interesting. Let me go down this path of looking at ways in which we can reform Medicare to save Medicare. And you showed us the example, Mr. Secretary, of Part D and how the choice and competition within Part D actually drove down the projected price. And let me make sure I just understood what you just said. You're saying that the cost of the program has come in $247 billion lower than the estimate of the program was?
If that's the wrong number, it may be
no, I think that's right.
Maybe 243.
Okay. So about a 40% reduction?
Yes, it's 40% reduction.
40%
and it might
reduction.
be pointed out that we have enrolled 93% of those who are eligible in about a year and a half, and 86% of them are happy, and the 14% who aren't have a recourse. They can go off and find a plan that they like, and they do. They change plans when they're not happy.
Because they're not stuck with the government monopoly.
Well, and we've created a generation of very astute consumers. I can tell you that there was some skepticism when we started into this, and frankly, people were a little grumpy about it. But they like it now a lot because they have choice and they have information and they've driven the quality up and the cost down.
I think that just from a Wisconsin perspective, I held a bunch of these sign-up fairs in 2004 with your predecessor, and there was a lot of concern, a lot of angst, a lot of just confusion, and we don't see nearly that amount that we did back then. And so it's encouraging to see that a market-driven idea, which gives the individual choices, has actually driven competition, brought costs down, improved quality, choice, and satisfaction. I think it is not a huge stretch to say that if we try that idea somewhere else in government, it may produce the same results. That's something that is kind of novel, I think, around here, but something we ought to take a look at. And this kind of goes to the heart of the healthcare debate we're having today. You mentioned sector versus system. I think it would be roughly the same as saying that we really have a healthcare market rather than a healthcare system. And if we systematize healthcare, as some will propose, in your opinion, will that make the market more or less efficient? How will that affect patients? If we systematize the rest of the healthcare market in that direction, rather than injecting some of these market reforms that involve giving patient more power and choice?
We just know at every point it is deployed that when consumers have information about quality, when they have information about cost and they have choice, the cost goes down and the quality goes up. We've seen it in nursing homes. We've been able to provide people with information about nursing homes, and one thing we find is that when we publish information about the quality and the cost, and there's a comparison, we see the quality go up and the costs go down.
One thing that I'd like to make in an attempt to do a reach across the aisle with my Democratic friends in the majority, an area that I think we ought to be able to have some consensus on. There's a bill I have with Senator Clinton on this issue, and that's the issue of transparency. We just had the 45% triggered. The minority leader and the majority leader just introduced the bill as required by the law, which you sent up. The means testing on Part D, I understand that's going to be controversial, and I don't know where that's going to go. Medical liability, I understand that's controversial. I don't know where that's going to go. But there's a third, I think people are looking at me telling me where it's going to go, but there's a third, there's a third element to it, which is this transparency aspect, this transparency policy that you produced. The first two, I think we all know those save money. You know, means testing or income relating, and medical liability. We know that saves money. Can you explain to us how and why this transparency initiative, number one, what exactly is it, and how and why that can help save money? And I would like to simply say, humbly, that this is something Republicans and Democrats ought to agree on, that we ought to be able to work together on this. So if you could just go into that, I'd appreciate that, Secretary.
Let me just add that in every system that I know of that's a large socialized system outside the United States, the most poignant political issue right now is how can we create more choice and also some sense of consumer pressure. And so this is not just something that is about those of us who believe it ought to be conducted in a private way. There are four cornerstones in my mind to how you create a competition based on value. Or the first is electronic medical records. We have to connect the system. The second is measures of quality. We have to know what quality is in a way that's been agreed upon by the medical family. The third is to have price groupings where ordinary people can understand how much it costs. And then fourth, we've got to structure the system so everyone has a motivation to drive quality up and cost down. Now, we're making substantial progress in the area of electronic medical records, being able to create standards. We need to drive adoption, but we also need to continue to drive the standards issue. On quality, we have the medical family now working together to develop standards. Actually, I've been in South Carolina and in Wisconsin working with local collaboratives that are working to develop measures of quality. We're now getting to the point that those are standardized.
Can I ask you right there? This is an issue that is difficult to get your hands around, quality, because of risk adjusting and other things. What you'll eventually get into these conversations with, let's just say, replacing a hip, and the American College of Orthopedics will say, well, you know, replacing Jim's hip or my hip or John's hip is different, and you can't measure the quality of these procedures because it's apples to oranges to bananas. Where is the industry in able to get an accurate measurement of quality? Number one. Number two, do you believe we're getting through a lot of the resistance that we have received lately from the provider community on being willing to submit their data to standard quality metrics?
The American Medical Association and many of the, and most, maybe I should say all, of the professional societies that we're working with to define quality have been extraordinarily helpful. We have formed the Ambulatory Quality Alliance, which includes not just the physicians and specialty associations, but also the hospitals, the large payers, the insurance companies, and CMS and other government agencies. And we are collaboratively now getting down to the hard job of defining what quality is. Now, frankly, we're not very good at it yet, but we're getting better, and we're getting more and more measures, and we're beginning to see this happen. In various places around the country now, you can literally get a copy of, or you can get a table that will show how many procedures a particular physician performed, how many of them were done at a particular hospital, how many hospital-borne infections that hospital had. Next month, Medicare will begin to publish a table on the internet where you can take any hospital in the country on any procedure and determine how much a hospital charged how much they charge statewide, and how much the national average, and what the patient satisfaction was. We're beginning to know how to do this. Now, we're not at the point we have to be, but when you begin to put those into place, this system can, in fact, be formed. What we have now is a sector. We've got to systemize it, and when we do, quality will go up and cost will go down.
Charged, is that just Medicare charges?
Actually, the system at CMS is. However, there are other systems that are beginning to develop. We're weaving a network of what we call chartered value exchanges. We now have 14 of them. I expect by the time we get to the end of the year, we'll have 30. These are local collaboratives that are using the same standards of quality and the same standards of health information technology to begin to weave into place this system.
And price standards?
And price standards.
Okay, well, I could go on and on and on. I don't want to abuse my time. I appreciate it. Who was first over here? Mr. Okay, thank you.
Thank you, Mr. Secretary, for being here. I have a comment. I would like to, given more time, get into this philosophical discussion, but I have something more specific I want to deal with. But I did just want to say this. My blood pressure goes up when I read in your description and your testimony that there are two competing philosophies about the role government should play in health care. One is a Washington-run, government-owned plan where government makes the choices, sets the prices, and then taxes people to pay the bills. I don't believe that's a system that, frankly, any of us really expect and want. The other, supported by the administration, is a private market where consumers choose, where insurance plans compete, and where innovation drives the quality of health care up and may drive the cost down. Now, we are all for electronic medical records. We're all for measures of quality. But based on my experience, talking with my constituents back home, I simply do not believe that price and quality transparency is going to, across the whole range of consumers who are looking for health care, is going to drive them to this miraculous higher quality, less efficient system. And I didn't really want to get too deep into that. But let me come to what it looks like to me. It looks to me as if the administration is simply cutting budgets and letting the states deal with the consequences, the states and all the different people and individuals who are involved. For example, this new, the new Medicaid regulations that the administration has issued, the regulations include changes to targeted case management, rehabilitation, and school-based administration and transportation services. Taken together, these 7 new regulations result in cuts of more than $12 billion over the next 5 years. Now, in Maine, a lot of this is a direct cost increase to the states. In Maine, Governor Baldacci's office has informed us that these new rules could cost the state of Maine $45 million in the next 16 months. That's 1/4 of the deficit that the governor and the legislature are struggling with. I want to focus on the Tcm rule, which is scheduled to go into effect on March 3, just 6 days from now. That rule would limit the period of coverage for case management services for people transitioning from institutions to the community. It would disproportionately affect individuals with disabilities and mental illness, low-income seniors, and children in foster care. I've heard from dozens of providers in Maine, including Day One, a substance abuse treatment center, Penn Bay Healthcare, Midcoast Mental Health Center, as well as families with foster children who could have their services cut if this rule goes into effect. Mr. Secretary, very simply, there is a lot of opposition to this rule on the Senate side. There's opposition in the House. You're hearing from the governors of their opposition. Will you delay implementation of this rule?
Mr. Allen, Medicaid is a partnership with the federal government and the states. We are all serving the same people. It is a dispute, however, between partners, and I suspect there's nobody in this room that's in a better position to understand both perspectives than me. I was a governor for 11 years. I think I understand where the states are coming from on this. I've heard from many of them. But if I could just put this in unvarnished terms, I would like to. There are a number of areas that we have issued rules where we believe that states are using ambiguities in the regulation to unfairly increase our share. And let me explain to you how this works. I know you may know this, but this is driven by consultants who get paid a contingency fee by being able to find any area in the law where there is the breath of some kind of ambiguity, and they have no incentive but to push the limits of what should and could be paid for by Medicaid. We have to push back by becoming explicit in eliminating those ambiguities as they happen. And when they do, it's then represented as though we're pushing costs off onto the states. I'm trying to be a steward of the federal position here, and I need to be able to push back on occasion when these fee-based contingency consultants find new ways, and they have no incentive to do anything else because they get paid. And
Well,
I need support here, not criticism.
Yeah, but isn't it true that you're changing rules, some of which have been in place for a considerable number of years, and that the states and the providers and the agencies have come to expect? And it's not exactly pushing back on something that has just happened recently, from my understanding.
Well, let's just take the targeted case management as an example. You don't have to believe me on this. Believe GAO. The GAO report itself. Two examples. One state, I won't name the states unless you ask me to, hired contingency fee-based consultants. They had $17 million in federal reimbursements, according to GAO. In their audit, they concluded that 12 million of the 17 million weren't really eligible, but they were, they were pushing the system. Another one had $76 million, 3 different programs in non-healthcare agencies. I'll give you an example. This is one that's often cited, schools. None of us disagree with the fact that if there's someone at a school that could be enrolled in Medicaid, we ought to have somebody there to help them. Well, in reality, what they do is they'll have a person at the school whose job it is to enroll somebody, but a large percentage of their duties are actually other school duties, but Medicaid pays the entire bill. Now, if I'm a governor and my county is dealing with me in that way, I would not like that, and I don't think the governors would either.
Well, let me just, my time is up. I don't really want to extend it, except to make this point. This grows out of the fact that Medicaid is, in fact, a partnership. And so what we have is the two partners quarreling over who will pay which bill. But the bottom line is that when you pull back on what you've been funding in the past, and then you're simply moving that burden to the state or to the agencies, and you're leaving behind the people you want to help. I could just as easily, in contrast to the argument you made earlier, I could just as easily make the argument that our system is so complicated, so entwined, that we've spent a lot of time, particularly in the private sector, not just the public sector, arguing over who pays the bill and which bills they pay. We've got so much excess bureaucracy built into what I think you defined as competition, that there may be a piece of the problem that we're really struggling with as a country. And I
would argue that point, because I think you're right.
I think I'd better go on, or I know we do. I will withhold and recognize Mr. Garrett.
I thank you, and I thank both chairmen, whoever's. Thank you. And thank you, Mr. Secretary. And to begin, I guess I'll just follow along some of the line of the question that was here. During this presidential election, we hear so much talk about new medical plans out there, whether we should have a universal health care plan in this country and what the benefits of that would be. And so much of the attack always is saying that the current system isn't working to the degree that the American public wants it to, and that the current system is a market-based system, and that's what we need to move away from. This goes some of the argument to a more government-controlled central plan. But help me out with some of the numbers. If you were to take all the people in the country right now who are in Medicare and in Medicaid and in other government programs and in the VA, and you combine them all together, what percentage do they make? What percentage of the American public right now is really getting their health care under a government health care system?
Well, under Medicaid and Medicare combined, it would be under 30.
Yeah. And then and as a percentage then out of the population?
Under 30%. It would be under 30%. Is that what you're asking me?
Under 30%? Mm-hmm. And then you add veterans on top of that?
You can get public expenditures if you include all public expenditures, right. Indian health, state, federal employees, you can get up to about 39%.
Yeah, about 40%. And then on top of that, you have the fact that most Americans, if I'm not mistaken, you can correct me if I'm wrong, don't buy their own health insurance. They get it through their employer. So if we really talk about a free market-based system where I, the patient, have a patient-directed health care system, my understanding it's in just a high double-digit, like
It's a very small percentage.
15 some odd percent. So the assertion on the other side sometimes that we're in a market-based system and that's not working for us and we need to move towards a government control system, the facts really don't support that. We're really already in a government-dominated system. Isn't that correct?
And in order for even those who are employed and have employer-based insurance to be part of that market, they have to have information about the quality and the cost so they can make judgments on value. Right. That's what's absent now, is that none of us have information about what quality is or what cost is, and the result is we essentially don't make decisions, and the market just continues to go up because we pay on volume, not on value.
Right. And so to go along the lines of Mr. Ryan here is, if you really want to have a patient-directed system or a doctor-patient-directed system, the decision-making factor has to be follow the money, which would be with the patient then, as opposed to the government.
That is my view.
Okay. On a other unrelated note, with regard to S-chip, at the end of last year, Congress passed and the President signed legislation that extended S-chip through March of '09. And at that time provided an additional $800 million in funding to cover the so-called shortfall states, New Jersey being one of them, those states that would not have had adequate funding to cover their eligible S-chip populations. There was a lot of debate on that. Both Congress and the President rejected a proposal to greatly expand S-chip program beyond its original intent back then. And yet, in the President's budget request now, he proposes an additional $2.2 billion in S-chip spending for fiscal '09 and 19.7, almost $20 billion over the next 5 years. This is a huge increase over his request of just last year. And some of us were standing with the President on his number last year, saying that that was the right number. A year goes by, and now we're looking at a $20 billion increase at this point. So my first question is, what happened over that time, and what do you say to those of us who are standing with that number?
Well, first of all, thank you. And then second of all, let me reconcile it for you. First of all, the President's number last year was just under 10. We had 5, and then we had 4.8, I believe, of money that was still in the previous allocations. The number this year is 19.7. I believe it's about 10 billion difference. What we've attempted, the most important change is for us to drop 1 year and add a more expensive year, which, if we're working to develop a policy, to fund the policy, that's what we would need to do because we've got a new period. The second is we have more updated information about the number of children. What we've attempted to do is to take the policy that the Congress passed and put into place a budget that reflects that policy. And the budget numbers reconcile.
And that's not what the numbers were, what the President was trying to do last year when we were throwing out those other numbers then.
Well, again, we have better numbers this year than we do last year, and we added a more expensive year and dropped a less expensive year.
One last question in my last 12 seconds is that also in the President's proposal is to provide additional funds to provide greater dollars to the states for outreach purposes to try to bring in the uninsured kids. A report that the HHS came up with shows of around 689,000 uninsured children with incomes under the 200,000 level were eligible but not enrolled in S-chip. I guess my question here is, we're already providing an incentive to the states because there's a 2-to-1 matching for the states as far as the S-chip program. Seems to me to be a substantial incentive already for states to do it. Here, if you divide the numbers up, it's around $450 million over the period of time. Off the pack of paper, it comes down to around $100 or $200 per child that you're going to try to bring in. Aren't we already giving enough incentives to them? Isn't it the state's responsibilities to bring them in? And finally, isn't it ultimately the parents' responsibility when we already have a federal program to provide free health care to their children that they should have shown some responsibility and not the other taxpayers to give them additional funds to pull into a system?
Yes, yes, and yes.
Okay.
And may I just say our goal here is to identify those children who are under 200% of the poverty level, do our best to enroll them first, and we felt there was a need for us to aggressively do that. I think that was the will and the policy of Congress, and we attempted in this budget to reflect that.
Okay, thank you.
Ms. Schwartz.
Thank you, Mr. Chairman, and appreciate the opportunity to ask some questions. Had a chance to do that, I guess, a week or so ago at Ways and Means, and then did submit some questions for you. So you may know the direction that, if you've had a chance to see them, you may know the direction I'm going to go in. You know what? And I think I'm going to try and find a place where we agree. Okay, and we're always looking for bipartisan cooperation here. So I really want to talk about the fact that budgets, I do believe, are moral documents, and there's a great deal of concern about health care and health care costs and how we contain them. I do think we should start with the goal, and I would define the goal very differently than Mr. Ryan does, but I define the goal that under Medicare in particular, we're going to try and get quality health care needed by seniors in this country in the most cost-effective way possible. And I agree with you that cuts, particularly across-the-board cuts, not targeted, not directed, but across-the-board cuts in Medicare, particularly to our hospitals, for example, are not reform. And I agree with you. You just said that, and I really do agree with it. But where we do agree, at least rhetorically, is that there are ways that we could make the Medicare system, the payment system, really encourage quality, demand accountability, and to be able to better assure quality. And there's several ways of doing that. You've talked about some of them, and certainly so have I. Electronic medical records, comparative effectiveness data and distribution of that data, some of the data you're talking about, but really using that in a very effective way, encouraging e-prescribing, which I obviously have a bill on I'd like to see happen. But in fact, in the budget does not reflect those priorities, nor have been the statements from the administration to encourage that. So we included some of this language, for example, in the legislation that we didn't finally pass, the CHAMP Act. We didn't hear from the administration saying, good idea, let's do that part of it. The fact is that in your budget, in the President's budget, comparative effectiveness research and the Agency for Health Research Quality is actually cut. So instead of moving in the direction of saying, okay, we are not going to just randomly, arbitrarily cut reimbursement, we're going to actually be smart about this. We're going to use technology. We're going to make some investments. So instead of saying to our hospitals, we're going to help you do electronic medical records, we're going to help you do e-prescribing, we're going to reduce errors, demand transparency and accountability, disseminate the most up-to-date information possible, share with you quality at a neighboring hospital you may not know about, and really make it more efficient, more effective, and higher quality. And yet your budget actually cuts those areas. So I ask it as a question. I'd like to see these things happen. I think we have an opportunity to do it through Medicare. I think it can be a huge driver towards quality and efficiency and savings, both of lives and of dollars. And then we can save those dollars. That's reform. That's changing the system for the better. It gets health care that we need to people without saying to our hospitals, and there are hospitals in my district, they're saying back to me, Congresswoman Schwartz, you're telling us we should do electronic medical records, we should encourage these things, but in fact, under Medicare, we're getting cut. We have no idea how we're going to make up those millions of dollars. So can you explain how the rhetoric does not match this budget and does not make the kind of investments that truly could make a difference in both lives and dollars?
First, may I say I'm pleased about the things we agree on. Second, let's talk about comparative effectiveness. As I recall, this is a big budget, but as I recall, the reduction was $9 million.
That's correct.
We spend that much at CMS on comparative effectiveness in a week. The fact that that particular line item might have been reduced is likely because we were doing it a lot in CMS and we're doing a lot of it in FDA, and we're doing, so to say that one item was reduced a little and then assume that we don't believe in that as a tenant would not be correct. We have a strong belief in quality and finding ways to do it. May I address the larger issue you raised?
Yeah. But do follow up on how you could speak to what else you're moving on. I mean, I understand we just have this report from the GAO about some of the work that's being done by CMS that's moving too slowly, basically, according to them.
I would concur with that. Nothing
and that we need to move much more quickly and much more aggressively to make this happen.
Well, if we can sign up for more aggressive, I'm there. So much of this would be driven faster if consumers had information about what was quality. And where we ought to be investing is in how we can bring together a system that includes the 4 cornerstones I've spoken of earlier. Our time is up, but this is an engagement I hope we'll have on the next
And
round.
yeah, and I know that my time is up, but let me just say this is one that I think we do have to move beyond the rhetoric, and it is not only tools for consumers, but it really is also tools for healthcare providers and hospitals. In Pennsylvania, and you know Pennsylvania, some good work on this with the Healthcare Cost Containment Council and the Patient Safety Authority, and some of the work we're really doing. It is a way for hospitals to look at each other. Because really, if you're having a heart attack, you're in an ambulance, it's not when you call the Healthcare Cost Containment Council and say, would you send me that brochure so I can compare which hospital to go to? It really is the hospitals who are actually saying, wait a minute, I don't want to be 10th on the list, I want to be first on the list for quality and efficiency. So it is, to just say, let's wait till we can get it to the consumers is actually just too far down the line. We really have to use Medicare and use the power of your office and ours, to move this much, much more quickly and to not just have the same discussion next year and the year after, because then what we're doing is slashing quality, and that's not what we want to do, because we're just cutting services arbitrarily rather than where we really know it would not make a difference.
Mr. Chairman, would you indulge a 60-second response, or would in a 3-month period, starting last month until 2 months from now, I will be in 40 different metropolitan medical markets, meeting with their medical family, where we have discovered many, I'd say more than 100 different groups in communities working to crack the code on quality. And we're working to bring them together into harmonized standards, not just with quality, but on electronic medical records, all of which is aimed directly at this. Government has a role, and it is, and we're working to move this as rapidly as possible. There are some natural barriers to this that we don't have time to talk about today. Amen. Could you write me down as being for that?
Mr. Conaway.
Thank you, thank you, Mr. Chairman. Mr. Secretary, 11 years as a governor, however many years as Secretary of HHS. Have you had any experience at all in which an organization you're dealing with, either a state agency or one of your subordinate agencies within the deal, that you decided would get less money than they thought they were going to get, or actually less money than they'd gotten the year before, where they thought that was a good idea?
No, sir, I have not.
Me either.
At least seldom.
Yeah, and I've never come across that yet, where that a legitimate cut where there's less money or a reduction in the rate of growth wasn't seen as the end of the earth. We use the word reform in this arena, entitlement spending others, and that's a kind, gentle word that has no meaning. I think we have to begin to use the word renegotiate. You're attempting a renegotiation with the states and Medicaid in this arena, where they have stretched the original intent of the rules to game the system in effect with professionals, and whether it's the group nursing homes or in this instance some other things that you mentioned. Those renegotiations are going to have to involve people getting less money than they thought they were going to get, or less money than the rate of increase. And so I just don't think you can have your cake and eat it too in this arena. They're going to have to be, as a result of renegotiations, folks are going to get less money. In that regard, can you talk to us any detail you want on this? Let's like the proposal, $113 billion reduction over 5 years on reimbursements, the premium reform proposal, other kinds of things where you're showing the savings in this entitlement arena on the budget. Just cuts like that are very dry on the paper. How can what do we expect to actually happen with respect to providers as they deal with this?
Well, let's go back to this issue of our relationship with the states, which I've spent a big part of my career thinking the way they are, and so I guess it's appropriate that I'm now having to deal on the other side of this negotiation. But it's become clear to me that they are in some cases driven by these contingent fee consultants who have little to lose from just pushing as far as they can, knowing that it may take us years, absent this kind of a rule change, to beat them back through court. For example, states, we routinely pay public hospitals a little extra money for a legitimate reason. So states have, through their consultants, have figured out that if you appoint a lot of hospitals as public hospitals, you get a little extra money a lot of places. And then they sweep that money up and they put it into their general budget. And that's the money that they use to pay their match. So they're taking our money and paying our match, which we match again. Now that's a very clever approach, but it's wrong. And it isn't a true partnership. And what I'm looking for is a partnership where they put up money and we put up real money. Now, I understand the need for them to put, when I say the need, I understand why they do that. But if I'm running a program with integrity, I have to push back. Otherwise, we have no negotiation here. We have no integrity in our partnership. And so, as I said, I'm not surprised by the criticism. I'm not surprised by the lobbying campaign. I'm not surprised by the fact that we end up with every medical constituency who gets that money and every school district that gets that money and every rehab program that gets that money are somehow coming back saying you're cutting services. Well, the reality is we're cutting off their staff person who's also doing other things that we're picking up. And it's been driven by consultants who get paid a portion of it. And there's a lot of criticism of this. But this is good program management that we're doing. And it's saving $18 billion that can go to medical costs for poor people. And that's what it ought to be doing.
Thank you, Mr. Secretary. Yield back. Thank you.
Mr. Doggett.
Mr. Secretary, I'd like to explore just how good that program management is and the issue of waste, fraud, and abuse, and just continue the discussion that you and I had 2 weeks ago this afternoon in the Ways and Means Health Subcommittee. Just to be fair to you, let me just go back and quote to you my last question to you and your last answer to me. And it was, I asked last June and again in October. We've submitted it in writing. We've asked it orally to tell us what happened to the $100 million that you wasted in paying private insurance companies for retroactive coverage for low-income beneficiaries that they were never told about until too late to take any advantage of it. I still don't have an answer. The Health Subcommittee doesn't have an answer to its written questions. Do you think before you come to testify before the Budget Committee this week or next, because we thought it was going to be much earlier today, when I get a chance to ask you about this again, that you could please bring us these answers that have been due since last summer? And your answer, Secretary Leavitt, was, quote, that seems like it would be a smart thing to do. And my question to you today is, have you done what you said would be the smart thing to do and brought the answers to these 8-month-old questions?
I do not have them with me today. I don't know the status of them.
Well, it's incredible. But so is some of your other testimony. Let me
They were,
ask you
Mr.
about,
Doggett, provided. Just so
no, sir, they have not been provided to my office as of the beginning of this hearing. If they've been provided, it's while you've been testifying.
Well, that's
let
not
me
the
ask you
information
about the
I have.
$150 billion of waste that Chairman Spratt asked you about, and the two reasons that you told him not to worry that we'd spend $150 billion in the Medicare Advantage program. First of all, this is not a new program. And we have seen year after year promises like you made today that eventually this was going to save money, and year after year we've wasted money on it. We now have the Congressional Budget Office telling us we're about to waste another $150 billion. And the two explanations why Chairman Spratt and this committee shouldn't worry about it that you gave were, first of all, that if we refine the bidding process, it'll all go away and it'll become a real bargain. I asked you about that 2 weeks ago, whether you or any of our Republican colleagues in any of these committees had ever offered a single legislative proposal to do that. Have you done that in the intervening 2 weeks?
Mr. Doggett, as I told you last year, this program is now 3 years old, and we're at a point where we ought to be looking at some serious
sir.
refinements.
Fortunately, in less than a year, this administration won't
Perhaps
be
I
here.
could finish my answer, Mr. Doggett.
Well, you haven't answered. If you'll answer, I'll let you finish. But the question was, have you in the last 2 weeks come up with the legislative proposals that this administration couldn't come up with in the last 7 years? And isn't the answer just simply no, we haven't done anything?
We have not advanced proposals,
Thank
but it
you
is
for your-
time for us
thank
to
you
be
for your
working with the
answer. It
Congress
is
to do
past
so,
time.
and
We can agree.
we're very
We can
willing to
agree
do
on
so.
that.
We're very willing
Now,
to do
the
so.
second answer-
But we
second
ought to do
answer
it
that you
because
gave to-
Medicare Advantage is a good thing. It provides
I understand.
important benefits, and
You
that's where
have
that
a
money went, was to
strong-
benefits.
And that's my second question. I'm glad you touched on that because that's exactly where I was going.
Good.
The second excuse that you give to Mr. Spratt about why we shouldn't worry about this wasted $150 billion is, well, the benefits all go to the beneficiaries, what you were just telling me. And the question that I have for you, sir, is why has your department refused to require these private insurance companies to notify us of exactly what benefits went where? Instead of just giving us a little anecdotal evidence, we don't know whether these benefits have been used. We don't know if these benefits have been effective. We don't know if these benefits have been worth a fraction of the $150 billion that we're about to expend on them. Why does the department refuse to obtain that information?
Congressman, your colleagues in the Congress made a decision that they wanted Medicare Advantage as a choice for people to be a national plan, and they have accomplished that in the way that I have described. And
Sir?
it has been a very successful program. Now, in terms of your question,
Yes, sir. In terms
I'm
of my
not
question.
exactly sure what you're asking, and I'd be happy to respond if you want to put it to me in writing so that I
Well,
can
I'm
go
not
to
sure you're
go
going
to
to
the
be in
people who
office
manage
long
the
enough to
program. and
answer
ask
to it if it's at the same speed as the little $100 million question that I asked you last year that you won't provide us. Do I understand also, Mr. Secretary, that in answer to Chairman Spratt and the problem that our healthcare providers, particularly our physicians, have all over this country about how we change the formula under which they're paid, that you have no legislation and no ideas how to fix that other than this ideological commitment to privatize Medicare?
That's, first of all, no small matter.
But you don't have a proposal on how we can
I
provide for
put
a
forward a
reform of that.
proposal with respect to that in the trigger legislation. And I would also suggest to you that while that may not, in fact, be scorable in your terms, it will save money. And I would also suggest to you that that the solution to the problem of the SGR fix is something that Congress has to fix. I don't have the capacity to do that.
Finally, Mr. Secretary, you're aware of the Government Accountability Office report, a bipartisan request from Senator Colburn and Senator Carper on improper payments that federal executive branch agencies made last year. Your department had 5 of the 14 reports of improper payment, and on 2 of them, you could not even provide a report estimate of when you could tell us how much had been improperly paid. That was Medicare Advantage and the Medicare prescription drug benefit. Since that came out almost a month ago, do you have any estimate now of when you can estimate how much was wasted on these 2 programs?
That is not information I have.
Thank you, sir.
Thank you, Mr. Chairman. Mr. Secretary, I have a number of questions. I won't read them. I'm going to submit them for the record and ask if you will please to respond in writing so that we got several votes coming up and that will take a extended period of time not to keep you here.
I'd be happy to respond.
Thank you.
Mr. Scott.
I had one quick question, if I could, and that is if Medicare could provide the services generally provided under Medicare Advantage for less than the subsidy that we're providing, could we do it better ourselves in this private thing where we have to pay a rebate? And if you're not prepared to answer that, you can answer.
Well, I have no way of being able to respond to it in an authoritative way, but I do know this, that whenever we have provided people with choices in a broad enough area, competition has driven it up, the quality up and the cost down, and I have no reason to believe that that wouldn't happen here too.
That means you could not provide it cheaper? We have to pay a rebate right now.
I'm not sure who, would you restate your question? I may have answered the wrong question.
Medicare Advantage, we provide a rebate to help the private industries provide the Medicare Advantage. And my question is, if we just did it ourselves like we do Medicare, couldn't we do it cheaper?
The Congress made a decision to provide enhanced fee-for-service reimbursement in specific areas so that those who would like to have a Medicare Advantage product could. It was done always with the anticipation that once the program was well in place, that adjustments could and should be made in order to bring the reimbursement down, not just to the levels equal, but with the anticipation that in some ways it would be, some areas it would be below, and hence less expensive.
Thank you, Mr. Chairman.
Thank you, Mr. Scott. Mr. Secretary, thank you very much for coming. We
Thank
will
you.
conclude the hearing with this round of questions because we've got 4 votes coming up on the, 3 or 4 votes coming up on the floor. We don't want to impose upon your time further, but we appreciate your forbearance and your forthright answers to our questions.
Thank you.
Thank you. I ask unanimous consent that members who did not have the opportunity to ask questions of our witness be allowed 7 days to submit questions for the record. Without objection, it's so ordered.